So I think we're really fortunate today to have three consumers of evidence from government, from technical support deeply embedded within government, and from an implementer and innovator. So it's important, I think, also given the other two panels earlier today where we heard a lot about the benefits of research and heard about different ways to do research better, but let's hear from the consumers on what's actually useful. I know in my own work as an implementer, before I was a researcher, I found researchers very frustrating. And I think it's important that we hear about some of that. So I have instructed my panelists to go no holds barred and to be provocative and to be honest, because it just helps us as a community improve what we do. So I'm going to open it up first with Dr. Prakash. Given where you are in a state like Uttar Pradesh, which has, of course, improved in health indicators, but there are a lot of challenges as well, specific to immunization. Can you give us examples of useful evidence that you've used to inform implementation in the NHM, either specific to immunization or not? And also, what's been frustrating about using evidence and working with researchers?
Thank you. Very interesting question. Both the things are important. Actually, without this kind of research is very important because without that, government will not have any idea what next to do and cannot go to the next levels. So many times these researches are very useful for the government, for the system, and they are implemented and we achieve so many targets. But as you said, of course, at times it is frustrating also. So at times when some new project starts, some pilot starts in a very small area, UP is a state with a population of 230 million, and it is very difficult to handle this population and any program. So if somebody comes with a project for a few villages or say 2 blocks, not covering even 1% of the whole population, and even don't know what will be the usefulness of this research, this project, and sometimes it happens that even after completion of that project, you are nowhere. You don't get any benefit out of that. That is really very frustrating. And any time which is lost in that project, starting from the very beginning, giving the approval, then accompanying you for some meetings, some field visits, and then dissemination. This is very frustrating for government officers that what we are doing. But certainly, first you asked about the example useful program. So certainly there are many such examples, and I can give one recent examples in related to immunization program only. So 4 or 5 years back, I think in 2015, UNDP came up with this EVEN program, electronic vaccine intelligence network. So before that, if you go even 6 to 7 years back in the history, cold chain used to be a very big challenge in UP. We thought that it is impossible to maintain cold chain, and even the vaccine and logistic management were one issue. So whenever you go to visit a field, you will find that any vaccine virus in the purse without any cold chain, and if the cold chain while you visit, it will not be maintained either. There is no electricity for last 4 years, and vaccine. Even at that time, this VVM was not there on the wells, and no electricity for last 4 days. You don't know what happened to the vaccines, and sometimes even you will find that all the vaccines are in the frozen state. That is be 100% frozen at the district level. So this kind of challenge. So 10 years back, as if we talk about NFHS 3 and UP, the full immunization coverage was worst in India, and that was just 23%, according to NFHS. So now, out of that 23% also, how many children are actually immunized, you don't know, because of quality of vaccine and cold chain. So with this EVEN project, actually, we were able to, initially it was implemented in 2 districts, smaller area, and it was found useful, and then we implemented across the state. And now we claim actually that we have the best, almost perfect cold chain and even vaccine management. So cold chain has improved a lot, and later on it was implemented in most of the other states in India also, starting from UP. So nothing can be better than this. So this was very useful, very beneficial for us. But now, how it was useful and successful. So from the very beginning, from the planning stage, actually, government was involved. We were involved. All the discussions took place. We went to the districts. We discussed how to we implement it, and they implemented it. Later on, we adopted it and implemented across the state. And now, for last 2 years, even NHM is funding for that. But still, we are getting the technical support, the training support, and even the monitoring support and mentoring support from UNDP. That continues. We are paying for it, but UNDP support is there. So this was a very good example of some new thing coming up and later on implementation across the state.
Quick clarification before I move on. Was there a role of research or evidence through the scale up or when you did the smaller pilot in the two areas?
Certainly.
Can you tell us a little bit about that?
Evidence of that everybody can. But later on, around 2 years back, it was disseminated. This even cost-effective analysis was done, and it was very interesting that we got to know that we are not putting any extra money into it. Actually, we are saving money because the vaccine wastage has come down. So whatever cost is being, we are paying for this, for extra manpower or anything, for the equipments and for the maintenance. More than that, actually, we are saving on the vaccines. Although we don't purchase vaccine at the state, but center is procuring it at one state, but money is being spent. So if we are saving 50% vaccine, 40% vaccine, so actually, finally it was very cost effective. So that kind of analysis is also there, and now we are more confident on that area.
Thank you very much. I'm going to move on to Dr. Arup. So you're supporting the scale up of rotavirus, and you've obviously worked in different state contexts. So can you tell us a little bit about the type of evidence you find most useful when you're either supporting scale up in particular and in working across different contexts? Because we know in India our health systems vary quite significantly state to state. So in your work in either consuming evidence or commissioning evidence with the government, can you talk to us about different types of evidence you find useful? Impact evaluations process, is it monitoring? What have you found most useful in the past?
Thank you, Sapna.
I'm frustrated.
Okay, thank you. Luckily for me, rotavirus vaccine introduction, we had a lot of evidence. And I don't know how many of you are aware that when rotavirus vaccine was introduced in the program, we had the luxury of having evidence prior to vaccine introduction. Very few vaccine introduction had that evidence prior to introduction. So the National Rotavirus Surveillance Network was established before the vaccine was introduced in the country. So after the introduction, we had this evidence of a before-after, and that was a really good evidence. When we reached out to the states in phase 4 and phase 3, we had evidence that okay, this vaccine works in the Indian context. So that was really, really useful. And as I said, many other vaccines didn't have the luxury because we didn't have a pre-vaccine era evidence with us. I would just like to focus on something else, the frustrating part of it. And see, I have seen both sides of it. Because my projects we work with very active with the government, and also it's a donor funded, it's a base funded. So the challenge before me, what Dr. Roy was mentioning in the last panel discussion about when an intervention gets scaled up, like let's take example 8, and it's a classic example which has been discussed in every IEG, I think. When say the agency does the first 1 year in a state, so they hire a HR at a certain point. When you transfer it to NHM has their skill, they can't give beyond certain level. So that's a challenge for the government. But as an agency with a donor funding, my challenge is that where do I strike the balance? Do I hire a lower end resource and they take care of things not being monitored that nicely? Similar with technology. Do I compromise on a low end technology with low cost with the right that something may go wrong? Or do I go for high end technology, which when it comes to transition to government, again the question of the cost comes in. So it's not easy, it's a complex thing, it's not black and white, there are a lot of gray areas where I think it will time with trial and error will reach that point where we have that match between research and the next level when it gets scaled up the system. Frustrations, okay. That's other thing I'm going to talk about. Let's take an example of rotavirus introduction. So when we started off, two things were there. One was the impact of the vaccine. Is it relevant to India? Is there disease burden? The other question was around the safety of the vaccine. So we had also a safety network, surveillance sites established. So again, by the time we reached the phase 4, the safety was more or less established with evidence that okay, it was not, the interception rates were not high in the first world. So a very interesting example. So one of the last days introduced for information on rotavirus vaccine is across the country. So in December 2019, every state of this country now has rotavirus vaccine. So one of the last days which introduced this rotavirus vaccine was Kerala. I still remember I was there in the state workshop in Kerala, and I was all prepared with my safety surveillance slides because I was getting questions from the participants on the safety of the vaccine. Not a single question was on safety. You know, the question was, why aren't you giving PCV to Kerala and you are giving a rotavirus vaccine? Because he has pneumococcal vaccine. Kerala doesn't have a pneumococcal vaccine. So they wanted the evidence to show that your diarrhea burden in Kerala is more than a pneumonia. So just understand, so the evidence need also changes with time. So when we started that project, it was safety, we have established that. Now why this vaccine over that vaccine? So lots of evidence. Yeah, thank you.
One follow-up question. So you have evidence on the efficacy of the vaccine, but in terms of the actual scale-up and integrating it into the health systems, did you have evidence, or are you generating evidence as you go on what's working and what isn't?
Yeah, we're generating evidence as we go because the surveillance network continued in those sites which had established before the vaccine was introduced. Now it is converting to rotavirus impact study and continue. So we are generating evidence, and that's again I said it's not there for every vaccine. Rotavirus.
Now I'll turn to Ruchit. I have two types of questions for you. One is, as an implementer, as an innovator, what strategies have you used with policymakers? Because you did have evidence on your innovation on Khushi Baby. So what has worked for you in terms of having your evidence reach policymakers in Rajasthan or in other contexts? And what about you as an implementer as well, in terms of what evidence have you found most useful in terms of types and the frustration thing stands?
So I'll start with the second question first. I think as an implementer, our journey started very much with trying to gather evidence. And we started as a group of 3 full-time staff, 6 public health students that were trying to start this project as a nonprofit organization just established. So we very much starting from the bottom, not going to the top key stakeholders. And given our public health background, we were getting funding from research grants. We were approaching local NGOs. Once we got some evidence, then we approached Dr. Tak, who was the Chief Medical Health Officer of Udaipur. And we had to propose to him something that was a bit uncomfortable, which was doing a randomized control trial. He would have much preferred, and we would have also much preferred, to just saturate one area completely instead of having some nurses do this strategy and some nurses do that strategy. But he did oblige and he did allow us to go forward with that. But even then, we faced a lot of challenges in our rolling out of our intervention, right? Because the top-down mandates had not come for nurses to get rid of paper and to start adopting a digital system. So the evidence that we were generating was great, but we were already disadvantaged by multiple different factors. So we weren't sure at the end of this whole impact evaluation whether or not we would be able to present anything. We were very lucky to ultimately have strong quantitative results. But I think what was more important was for us to have a strong presence on the ground as an implementing agency, also come research agency. Not that that was our initial intention, but we did both implementation and the research. And we were learning constantly, changing the intervention constantly throughout that process. Now, when we had the results, then we did go to the state. We did do advocacy at the state starting with this past September. And we had to basically propose our mHealth solution against the existing government's, the state government's existing mHealth solution versus other established NGO solutions. As you know, there are many there's a menu of options now. Evidence did come into play there. Luckily, our additional chief secretary is very much interested in learning about RCTs, seeing evidence, and I think more important than just the hard evidence is also what is your experience on the ground say? What is the strength of your team? What is the commitment that you can take forward? And what do you bring to the table? Your intervention, frame the evidence to support that intervention in the right context.
And did you find a hierarchy between the type of impact you had in RCT? So of course you have quantitative, strong evidence, experimental evidence, but you did process work as well. And were you able to use the process evaluation work both as an implementer, but also the things that didn't work when you went to the state?
Yeah, so even though we all look to strong quantitative evidence as, and we think of that as being very important, there are other things that also make a difference. I think qualitative feedback, in-person feedback, when you have a health official go and interact, for example, with a group of health workers, ASHAs, and hear their feedback directly, that can be a very convincing and persuasive moment when it comes to whether or not that strategy should be adopted. So I think that human connection is very much important. Then the other component is the budgetary piece. So is this sustainable? What is the cost around this? Those three things have to all be in alignment. You can't just have strong impact numbers, but you don't have any face-to-face interaction or story to support that on any kind of human emotional level. And then the cost and sustainability piece also doesn't make sense. So you have to look at the existing budget, you have to look at what was the precedent that was set, where is the government trying to go to, and then all these things have to be aligned.
That actually brings me to another theme I'd like to hear all three of your views on. So there's probably a spectrum of partnerships that researchers engage in when it comes to government, technical support, and implementers, which is maybe an older way, which we hope isn't as common anymore, where there's a question that researchers find interesting, perhaps based on the evidence base, and design a study and go forth, and then go and present those findings to the government, which usually leads to a lot of frustration in terms of who decided which question should be asked. Then there's the other, I suppose there's co-design, being part of the implementation as it goes, and then the other extreme, let's say, of embedded research and actually having researchers work quite closely within government. You lose some of the external impact evaluation work in that way, but then there's a strength. I mean, I hear this a lot, for example, we're often approached to say, well, can you be embedded within X ministry or X implementation organization, rather than doing the types of studies someone earlier mentioned, incentives for researchers that get published, but actually produce evidence that's useful to us on a regular basis. So what are your views on partnerships in terms of what would be most useful to you in terms of the types of partnerships that you even have the time to engage in, or people in your teams have time to engage in, and what's most useful to you? So from a co-design to completely external or embedded.
Actually, in which field research is going to be planned, and what kind of research it should be decided in consultation with the government. If that is done, so we will be on the same track. So our criteria are something, and somebody comes who is planning something which is not at all in our criteria. So, or we don't think it will be useful. So that becomes frustrating. So if there is some kind of gap analysis is done, and then this is partners and the government sits together and decides that in which field we want to work. For that, in UP, we have actually developed some forum. We have a health partners forum. So in UP, around 50 to 60 health partners are working to support us, starting from WHO, UNICEF, and Gates Foundation to many other organizations. So we have this platform. So the Principal Secretary of Medical and Health, every quarter a meeting is held, and now it is also being once in a year. A meeting is also held under the Chairman Chief Secretary. He also meets all their partners. So they present that what they want to work, and we also let them know in what fields we want support. And then their plans are submitted, and that is followed also. And under that health partners forum, we have TSGs, thematic support groups. So we have under health various thematic areas like child health, immunization, maternal health, family planning. So 8 or 9 thematic areas are there. For each thematic area, we have a group of partners who are supporting that field. Like in RI, we have 8 partners. So which sit together. We have a TSC meeting every month. So that is how we try to decide in which areas this work. So mostly we try to communicate that what they are going to work, what we want, and accordingly we work. But even after that, sometimes some unknown partners come up, and sometimes even after they complete some work in some area, then they will come to us and tell that we have been working for last 2 years in that district, and we have done something, and we are not able to understand what they have done, whether they have done something or not. So it should not happen. It's better to be a part of our team, the TSC, because we have all that system built there. And then if they start working, that will always be useful. That I will get.
You have a unique platform in the state, which is great, and not all states, of course, have that in India. But what is the extent you're very busy, obviously, and your teams are very busy. What is the extent your teams would like to go in terms of partnership? Something I hear a lot is, well, we want to be part of the design, but we have no time to talk about that other agency, as opposed to actually having the time. Do you face those challenges, or do you see a mechanism for that?
We do face that kind of challenge. Being such a big state agency, we are always busy with so many files and so many meetings and everything. And sometimes it becomes difficult and embarrassing also that because some partner coming to meet us even after getting some appointment and we're not able to meet them. This also happens. But that has to be managed somehow.
Work in progress.
I would love somewhere in between core design and embedded, but closer to core design. Okay, I'll tell you the reason. And we agreed that we'll be brutally honest in this panel. One thing I think we haven't discussed is one. I'm sorry, I didn't attend yesterday's is the personality. It matters, trust me. So if you go to a district collector with an intervention which is tech-based, and if district collector is a fresh eye pass out who has got into emergency service, your chance of getting it passed is 10 times more than another day. So that's exactly is what we're all humans at the end of the day, that matters. And you know why it matters not only for research proposal, it matters for so many other things. And we somehow we don't capture that also. And now coming back to your thing that where do we position that, and why I say closer design is that I think somewhere I read that one of the problems that the program and policymakers face is that when you see the evidence, the language, the evidence is not understood by them. I think that problem can be easily get over if before you start it, have the dialogue. Understand the language they understand. Work backwards from there and then design it. And then somewhere you get it. So end of the study, you are not left in a situation where the program is telling doesn't make any sense to them. It's not a priority at all. So you have invested time, you have invested resources in something which, so sometimes for a government, if we have done something on their priority list which doesn't work, it's also important for them that they will know that this intervention doesn't work. That is also equally important. But if you go and do an intervention which, even if it works, doesn't matter, it doesn't work, also doesn't. So that's it. So we have to strike those balance.
You've seen platforms or mechanisms to make this work in practice? Have you been involved in co-design, or do you see opportunities to do that sitting where you sit in the ministry?
Okay, that's something interesting thing for our country specific, because we all are aware health is a state subject in our country. We work at a national level team, and the interventions happen at the state level. So that adds another layer of complexity to the whole thing. So something which looks very attractive to a national program manager, when that goes to the state level, may not. And it differs from state to state. And as the UP is lucky to have those structures in place. There are so many states which may not have those structures in place. And coming to examples where this has happened, again coming back to my introduction project, we have been lucky in that way because the partnerships that the collaborations were established, the platforms were established very early in the program. So we had, and I think many of you are aware, the rotavirus vaccine that is used in India is a locally manufactured vaccine. So it's from discovery till delivery, it happened in India. The strain of rotavirus vaccine was isolated from Institute of Medical Sciences. So right from the isolation of the strain, the manufacturer of the vaccine is an Indian manufacturer. So it's from right from discovery to delivery, it happened within the country. I think maybe because of that, those partnerships were established very early with research institutions, the implementing partners, and the company institutes. And that has been carried along right through the journey of global vaccine introduction, and it has really helped in the medical evidences.
So I guess the question is whether to co-design or. Right. So speaking from the implementing standpoint, we actually have a unique opportunity now as a technical service partner to the government of Rajasthan, specifically the Department of Health. And we are working very closely with the Additional Chief Secretary of Health. And it's a very interesting model that he has developed in which he invites many different partners to his office to share their ideas. He often will filter based on evidence, experience, who can contribute. But then once you come into a position where you are a technical service provider, basically your role is to work side by side with the company, with the department. You're not somebody external. When you're designing your solution or improving your solution or testing your solution or doing the training and dissemination of your solution, scale up of the solution, you very much need the government's help. And you basically then act as a wing of the government. So that has been a model that we've recently gotten to experience that we're very much excited about. Embedded in that model is a need to learn about how well the solution is being scaled, what are the challenges, what are the practical barriers. But I think that type of relationship, of course, requires the government to have a certain level of trust in you as an implementing agency. So, we're very lucky to be in the position that we're in right now, and to have a very close relationship. But I think ultimately, when you want to take an innovation for scale, you really need to be working side by side with the government to empower the government to take this forward.
And I'm sure when we open it up for questions, it'll be interesting to hear if we have other examples of different ways partnerships have been achieved. We often hear the challenges of these kinds of partnerships, but it's important to know there have been many successful mechanisms, both with NGOs and with state governments in particular. We have that added challenge in terms of whether the partnerships at the state or the national level actually matters quite a bit. My last question before we open it up is, given what we know specific to India with the variation in immunization rates across states, but also even between between different immunizations, right? There is considerable variation, particular to some states. What type of research, we had an earlier conversation about context specificity versus scale. You essentially need both. Maybe it's a difficult question, but would you like to see more and more research conducted very specific to a state system? Or do you want to see comparative work across states? Because we don't see as much of that. And there might be a reason for it, but would you like to see more? Because we hear more and more states learning from each other. Some states that have just performed so well in some of these, and we don't see the cross-learnings to the extent they could. So what role do you see for that type of research in terms of, I suppose, moving forward and helping your own context?
Actually, yesterday we saw great outcomes of various researches, various states, and some were found that had some significant. So, of course, if some new idea comes to our mind, somebody comes up with a new idea, I think that it will be useful. There is no harm in conducting that research. That can be useful. But I will say once again, yesterday also I was discussing with some of the colleagues. Any kind of these projects cannot be beneficial for all the areas, even for UP, even for one district it cannot be. I cannot design one capsule which will cure all the diseases. So for every disease we need different capsules, right? So like yesterday we got 7 or 8 kinds of capsules, 7 or 8 kinds of prescriptions. So instead of saying that okay, this was useful, found to be significant, so we are going to scale up to whole UP, I never agree to that. So the best thing is to that now we have 8 more tools, right? Coming from various states, from various studies and research. And before that also we will have many tools. So now 8 plus 8, we might have 16 tools. So locally it needs to be decided in the districts, in the blocks, that in which area, which tool which will be useful. Because even we know that there is a saying in India, the course par badle pani, char course par bani. After every 2 miles, water changes, or you can say weather changes, climate changes, and after every 8 miles, even the culture and language, everything changes. Huh? Yeah, direct. So that is how. So even in one district, in one area, the problem is different. In another area, the problem is different. So the same formula will not be effective everywhere. And it was a very great learning during the polio eradication. I'm lucky to be a part of that polio eradication part for 10 years. So when UP was a big challenge, the whole world was thinking that UP will not be able to eradicate polio, but we did it. How we did it? We started doing this thing only, this formula, that for every area we would try to find out a specific solution. So at that time we were needed to invent the wheels, we find some new solution. Now we have already so many solutions, 8 more solutions. So area wise we can decide what can be implemented. One thing cannot be scaled up for the whole UP, the whole district. That is what. Thank you.
And here we are, people are thinking countries across countries, and here we're saying not a block, not to the whole district. That's very important to hear. Arup?
Okay. Yeah, I'll agree with Dr. Ved. I think it is too fast, too diverse to have. But again, having said that, where to strike the balance? Having very specific research to that, and I think we will have to struggle with this question that how to focus. But I'll focus on something else. Most of the times we generate evidence on maybe the bigger evidence on coverage. Just okay, this coverage of this vaccine A is this, B, C, D, and we keep on having them intervention. We hardly have those evidence available determinants of those. Why this differs from those? Why vaccine A coverage is lower than B, B, C, and D, and that those determinants will differ across. So that's one of the key things that we need to focus more evidence on going forward if you want to scale it up. Because after you reach a particular threshold of coverage, once you reach your 70%, 70%, every person will be difficult. From 75 to 76 will take more effort from 30 to 70. And there you will need those evidences, those research, those very customized, localized things where to understand those behaviors in the community, take that from 75 to 80 and beyond that. It's not easy. It's difficult for our country. The other part, and this is again very unique to our country, is that we have this additional problem of migration also. So I don't know what's the latest data on it. Some point I remember I read somewhere. At any point of time, 25% of the population of Bihar is out of Bihar. So when you have that level of migration happening between state to state, and you have to factor that in also in the whole scheme of things. Not easy, but yes, the solutions are there. I just want to focus again on something else. When very state-specific interventions are designed, and I'll give an example of Rajasthan. I've worked there for 3.5 years with WHO. So when I was there, this system, there's people who work in Rajasthan know they have a pregnancy child tracking system, PCTS. Very nice, robust system. Very attractive. I found it very useful while in Jaipur monitoring data from there. I shifted base from Jaipur to Delhi. Then I struggled. I'll tell you why. Because in Delhi, there's only one system for the country's HMIS, Health Management Information System. So we have I don't know if it's still there in Rajasthan, there was a bridge software that will passively transfer data from PCTS to the HMIS. And that passive transfer resulted in loss of data. So since I knew that I was working in Rajasthan, so whenever the Rajasthan data, I said, no, it can't be that less. Okay, I call up my colleagues in Jaipur. Look at the PCT and tell me there used to be differences. So see, at the state level, it looks very attractive, very robust, but government has a different system in place. It was another challenge.
The dates are not there. And then the mother, we look and we ask, okay, did you receive this vaccine? Did you see that? they have the BCG mark on the left shoulder. Do we really know what's happening? Or can we actually trust that, and to what degree? And I think we take a lot of that for granted. I think that we don't know what the ground reality is. We look at numbers, we look at summary counts, we make rank lists, and we say we need to target resources here without necessarily knowing the ground reality. I think that's one focus area that needs to be addressed, and needs to be addressed honestly. Because if you don't have the right numbers, and if every year you're trying to improve your numbers, then you won't actually make any progress where it needs to be made. And in that regard, I think I'll give the example of Rajasthan. Rajasthan is now doing something a bit radical, in that it's doing a digital health census of the entire state. So 70 million people, hopefully, will have their health profiles collected, social determinants collected, GPS of their location collected. So that way you'll have an unprecedented source of data that can actually get to what the ground truth is. How many kids are actually living? What is our denominator? Do we actually know that, or do we estimate that based off some 10-year ago census that has been carried forward? So I think technology, data will have a huge role to play in this, but we really need to look very, very closely at all of the numbers that we are handling to see if they actually reflect the ground reality. And if they're not reflecting the ground reality, we have to come with strategies to make sure that the systems that are doing this monitoring, evaluation, or research can be strengthened to become more accountable.